Thank you all for having me. So I'm just going to take a few quick hitters at a few cases and how Radial approach offered some nice treatment options for a couple patients that I've had. Early in my practice, I've been out for 8 months, so it's already proven to be beneficial in just a few months of practice. Nothing to disclose. So it's my first job out of fellowship. I work at 3 hospitals in the Ochsner system. We have a large academic center, we have residents, and then 2 smaller kind of community hospitals. And when I was hired, one of the things they specifically wanted me to do was to incorporate radial access into the practice that's already there. We do a lot of oncology work at the academic center, and so there's obviously a role for that there. First case, this was a presentation of a 27-year-old female with a large AML that had ruptured. This was about a year ago before I arrived. She came to one of our community hospitals. Urologist consulted our IR there. First angiogram done by femoral approach. As you can see, the kind of a tough angle of that renal artery, and then the superior pole branch there that's got another acute angle. One of my partners worked on her for a while, and I think ended up never really able to cannulate that vessel. Did induce some spasm, which ultimately stopped the bleeding. However, she did well for a few days. She rebled a couple days later. She was transferred to the large center where a second interventional radiologist was able to cannulate a small vessel and embolize it. If you can see that small coil, but was never able to get into that kind of ugly-looking vessel that looks like it's rebleeding now. So they worked on her for a while and were never able to do it. She came back a day later for our third angio. This time we had 2 of our IR docs. We got bilateral femoral access. They put up a distal occlusion balloon and was able to infuse some particles into that vessel, which I thought was a nice way to deal with that. So we'll fast forward a few months. She comes back with a large hematoma again. Pretty significant compression of that kidney. She was hemodynamically stable. We weren't certain that she was actively bleeding at this time, but talking to the urologist, we wanted to repeat the angio. So this time we went by radial access, and what that afforded was a nice gentle angle of the catheter from above, and I was able to relatively easily with the microcatheter then get into that acute angle, superiorly oriented vessel, and to get into that and to pretty easily embolize that, although I don't think there was any evidence of active extravasation. We just empirically embolized it. As of now, she has not lost her kidney. Obviously, we were trying to preserve her kidney. She's a young female. But that was, within an hour, we were able to complete this case that had took 3 separate angios, 4 separate femoral accesses in a young female patient. So that's a lot of radiation, a lot of contrast over the course of a week. Just an anatomical reason that radial access can be very beneficial. And what that has afforded me, I got a good impression off from that referring urologist. He's referred me multiple cases since then. I've got other referring physicians asking me, you do that wrist thing, can you do that wrist thing if I send you this patient? And I say yes. Another case, this is a gentleman with cholangio. He had an internal-external biliary drain removed about a week earlier. Came in with presentation of GI bleed. His scopes were negative. CTA shows a pseudoaneurysm off of the hepatic artery. This was at the main campus. The resident went up to evaluate the guy. He was a pretty healthy guy, other than unfortunately having terminal cancer. But my resident comes back down. Well, this guy, he's a nice guy. He's kind of squirrely. He says he's got restless legs and he's got a lot of back pain. I don't think we'll be able to do this case without anesthesia. So we looked at him. He had a chest CT in his cholangio workup and showed a nice-looking arch, minimal atherosclerotic disease, and a favorable arch anatomy. So we said, well, I think we can do this without anesthesia if we go by radial access. That's what we did, and we were able to embolize that pseudoaneurysm pretty nicely, and we're able to do it to avoid getting anesthesia involved, do it under moderate sedation, and he did really well. Last one, this gentleman, 61-year-old male, recent liver transplant. I think no one still knows why, but he kind of just had a spontaneous rupture in the spleen, and he was getting kind of hemodynamically tenuous. So we got a quick CT and an ultrasound, and so we took him directly to the IR suite following that. He had been thrombocytopenic, platelets counts ranging from 30 to 60,000. I think they were 53,000 at the time of this procedure, and just another reason to access the radial artery with kind of a tenuous platelet count. I think the risk of significant bleeding following the access is less, and so we were able, just as you would via femoral approach, to get out there and lay some coils down and kind of take care of that splenic bleed. So quickly, how has it benefited my practice? Like I said, you have just more options to deal with challenging cases. I think patients like it overall if you just compare femoral versus radial access, and I think Dr. Gamaris is going to present some of that data at SIR pretty soon. And it also is kind of an attention getter from referring physicians. We got this guy, the new guy, and he's got some different things, and they kind of take note of that. And if you do a decent job, I think it helps in the long run. It gives you a little bit of kind of recognition. I've been able to kind of work with my new partners, and I've got two of the guys doing a large percentage of their cases by radial access now, and it's been able to help me develop relationships with them by kind of showing them the technique that I use and now that they now use. Same with my new nurses and techs that I'm working with, working with them and kind of showing them how to set things up and the equipment that's necessary to do it, just gives you a new platform to kind of build a good relationship with them. And so kind of the challenges is kind of infamiliarity, and the way to get around that, just to educate and kind of work alongside and kind of show them and teach them. Same with colleagues who say, well, what's the point of doing it this way? You can kind of show them some cases that it's actually beneficial to femoral access. I think a lot of cases, access is access, but certainly there are advantages in some cases, radial over femoral, and vice versa. There are some cases that you need to go by femoral access. And that's